This week we are going to be talking about MRI, MRA of the brain and the neck. Let's start with the brain. First of all, we have to determine two major different things, is MRI and MRA. MRA stands for magnetic resonance angiography, and we use it to look into the big blood vessels, arteries, and in our case we will be looking at the large arteries in the inferior portion of the brain. Landmark for those exams is going to be glabella. The position of the patient will be lying on his back, supine, head first. We would be very lucky if we have a choice of coils, and if we do, we will choose the most powerful coil. In our case, that would be high definition coil, and if we don't have that, we can use birdcage coil. The difference in the coils can make a huge role. For example, the high definition coil, first of all, we are winning here the quality of the image because the signal is going to be stronger, and also our scan time will be shorter. So in case of the advanced and high definition coils we want to use, our scan time will be about 5-6 minutes. And if we're not that lucky, we'll have an older coil that will give us the time about 13-14 minutes. So that's the difference in time. It is also very important to position the coil on the patient right. So we want the coil to touch the patient's shoulders. At the same time, we don't want to do it the way that the patient is in pain. So let's look at the angulation and positioning and anatomy of the scans. I'm going to describe the angulation and coverage for axial brain sequence first. So when I'm doing the axial, I'm dividing the brain in superior and inferior portions. So when we're doing an axial brain scan, we want to angle parallel between the genu and the splenum portions of the corpus callosum. So genu is the anterior portion and splenum is posterior portion of corpus callosum. We have here sagittal image, and it's clearly we can see corpus callosum. It's the largest piece of the white matter in the brain, and the corpus callosum located right above our lateral ventricles. So slice coverage in this case is from foramen magnum. It is, the opening in our skull to the vertex, which is like the very top of our skull. This is 3-plane view what we just did, and we know that we did axial because an axial image we see the boxes, there's no line across that. Let's move to coronal brain sequence. So I will dividing the brain into anterior and posterior portions. So it is front and back. So my slice angulation for coronal brain scan will be parallel to the brainstem of the sagittal image again. So this I'm taking sagittal image, and we clearly can see brainstem here. So the slice coverage will be from frontal sinus to the occipital protuberance. Occipital protuberance is that bump on the back of our head. And third one is sagittal. So sagittal, our goal is to cut the body visually in the center, left and right side we have to get. So for that, we can actually use both planes, axial and coronal. We have anatomy in our body there that's really symmetrical. Like, for example, we have a third ventricle on the coronal that will like really clear see we can see, and the midline on the axial plane, also like very very perfect anatomy for cutting like that. And slice coverage will be from temporal lobe to temporal lobe, or from ear to ear, like from pinna to pinna. So we also make sure that the ears are included. And one neat trick is a time saver at this point, because once we set all those three guys, axial, sagittal, and coronal slices, we plan them, and at that point we can use them. We can copy and paste them to other protocols, like we did T1, let's do the T2, and so on and so forth. So that's pretty good. Let's talk about circle of Willis. The axial block scan we run only for MRA of circle of Willis. We want to use the most powerful scanner coil for that. It is the neurovascular coil. The second choice would be 8-channel HD coil, and if we don't have it, birdcage coil also will work. The landmark for circle of Willis would be also glabella. It's exactly how for the brain. So I'm gonna plan my slices on sagittal image. For that, we run parallel line parallel to corpus callosum, genu at the front, anterior, and splenum at the posterior. So we have this parallel line. Then our slice coverage will come from foramen magnum up to corpus callosum. So that is easy thing to do. On top, we just run parallel line to the line we already have on top of corpus callosum. So make sure we have corpus callosum, the whole thing is there. And another thing that's important to add is saturation band on top, because we're getting all this enormous blood flow which we don't want to get the signal from. We have the big superior sagittal sinus that runs all the way on top, and we don't want the signal from that. After the scan is done, we have to do some more work to the image. We must do some post-production with the image. So for that, we have to use tool, scissors, or scalpel and cut out all the blood vessels that don't belong to circle of Willis. We do it so radiologist has a better view of the anatomy he's interested in, and that's why we're doing this post-production. So what we're getting at the end is dark, almost like a black background, and very bright circle of Willis. Also, it is necessary to mention that MRA of the head brain circle of Willis we usually do without contrast. Now it's time for the neck. For the neck, we're using neurovascular array coil, HD and V array coil. Our landmark will be the point where a little bit like 1-2 inches from the chin down, and the coil will also cover aortic arch and a little bit of chest. We need that as well. We put the patient again supine on the back, head first. For the coronal soft tissue neck slice angulation, we are going to use sagittal plane, and we are going to draw the parallel line to the spine. Field of view will include frontal sinus below the aortic arch. We are going to be covering nose on one side, and another side would be spinal processes of both C and T spine again. When we start doing the axial soft tissue neck slice angulation, we are going to use sagittal plane, but we are going to run our line perpendicular to the spine. We have to include nose in the field of view. Slice coverage for axial soft tissue neck angulation is going to be from frontal sinus down below to the aortic arch. Slice coverage for the sagittal soft tissue neck is parallel to the spinal column. We are using coronal plane for that. Field of view is going to be frontal sinus, and again to the a little bit lower than aortic arch. Slice coverage from ear to ear. MRA neck is when we're doing MRA on the carotid arteries in our neck. This is done with contrast. Contrast creates much better images. Time of flight 3D is not that good because we have a big area to cover, and it's really going to be a long scan. It might also miss small vessels. Patient again positioned supine on the back, head first. Laser landmark also 1-2 inches below the chin. There's one specific thing about it also, is that we have to time our injection. For that purpose, we will use a power injector. And again, we have to be ready. The patient has to be ready. So we connect power injector to the patient, and we explain to the patient what is going to happen. It is very important. We do not want to scan too early. We don't want to scan too late. We also have to time the injection at least 2 milliliters per second. If it's 1 milliliter, it's not going to give us what we want, good images. Also, when we set up IV, we have to do all the precautions as usual. I have to wash my hands for at least 20 seconds, then to put the new gloves. Everything, all the items has to be taken out of sterile packaging, brand new. I have to use alcohol on the skin and other things. We do sagittal localizer for MRA carotids. This sequence will help us to plan all other sequences. So on sagittal plane image, we will have the line parallel to spinal column. Field of view has to cover frontal sinus and then a little bit down below the aortic arch. Sagittal slice cover is from ear to ear. We have the sagittal MRA, so it's ear to ear. When planning axial time of flight for MRA carotids, we need to angle it perpendicular to spinal cord. We have to be careful with the field of view because we have to include all the vasculature. Slice coverage will be from base of the skull down to the aortic arch. That way we will see everything we need. We're interested in blood vessels at this point, and we'll see all of them, the one we need. We sure thing we will have some motion, but because we injected the contrast, it will speed up the process. When planning pre and post contrast field of view of our MRA carotids, we will include frontal sinuses all the way to the aortic arch. We don't use that thick of a slice, like for example for a brain, because that will increase our scan time enormously, about 20 minutes, and no patient, no human can hold on still for that long. We have to run pre-contrast so we can subtract it from our image later.